Our topic today is breast cancer and current updates in management. And I wanted to open this webinar with this picture of a patient that I received a year ago in the clinic at the Hope and Healing Center here in the village. And the mother you see there is 34-year-old, and she had been to several clinics. And if you notice just closely, there is a scar on her breast, but also there are lumps on her breast, and then there are axillary lumps. What was surprising to me is that when this patient came, she came with abdominal pain, of course, abdominal swelling, and she had been sent by a doctor so we could do an ultrasound scan because they were thinking that the patient had hepatitis B because had deep jaundice. Thank you, Professor, for sharing that. I'll stop my video. Yes, so I was saying the picture on the next slide, that this patient came and the story I gave you, to cut the long story short, is that they had done an excision 8 months prior to the visit to our clinic, and no one took the biopsy. And then I'd been to several, healthcare providers, but none of them examined their breast. Instead, they were doing multiple tests, including hepatitis C and alpha fetoproteins and CBC, but none had examined them. And this is a common story here in Uganda, that many of us clinicians seem to have forgotten our ritual as physicians, that we should take full history and we should examine our patients. So the patient died this year, actually. Our efforts to save her life were effortless because she had stage 4 breast cancer, which had advanced, of course, to the liver and other parts. So that's just a brief story. But if we go to the next slide, I will give you an overview of what is happening around the world and then here in Uganda. We see that just in 2020, there were 2.3 million women diagnosed with breast cancer, but among those, 685 died of breast cancer. And I think this is an underestimation of what is happening around the world. Like for some of us that are within the villages, some of these people never make it to the health centers or to the hospitals. They instead think I've been bewitched, and possibly they fall under wrong hands and they end up dying in their homes. So I highly think even that number is an underestimate of what is happening around the world. But in the next slide, we see that breast cancer is the leading cause of death among women, and as in globally. But in the US, breast cancer is second to lung cancer among deaths within women dying of cancer. But here in Uganda, I'm glad my colleague and senior Dr. Thieno Mosana shared about cervical cancer. We know the burden of the CA cervix in Uganda, that many of our women are dying of CA cervix. But breast cancer is, of course, second to CA cervix among women here in Uganda. And so I feel it's important for us as clinicians and the people that are within the healthcare circles to spread the word. Unfortunately, it has been, the negative news have overshadowed the positive news about breast cancer. As you know, that when someone hears about breast cancer, all they think is they are dead. And so some of them end up even not going to the hospitals because of the negative news. But we also have very good news of many of our friends, many of our patients, many of our relatives that have fought this disease and this battle of the breast cancer. The incidence of breast cancer is that 1 in 8 women, 1 out of 8 women are diagnosed with cancer within their lifetime. And that is a study that has been shown in the US. And despite that high incidence in the US, we have seen that there is a significantly a decrease in death due to breast cancer in the US, with a 90% survival rate for all the stages of cancer. But for the cancer that is localized, 99% survival rate, which is not the same story here in Uganda. We have a few studies that have been done here in Uganda. If you could go to the next slide. And we've noticed that over 80%, actually 86% of the patients that are presenting at the Uganda Cancer Institute, 86 of them have already stage 4 breast cancer, which is not good news for Uganda. And so studies have been done. What have been the barriers to the early detection of breast cancer? Why are our patients and our women, our mothers and sisters, why are they presenting for treatment at a late stage? One of them is the story I just told you in the preamble, that some of these women, possibly us as healthcare providers, we've missed the diagnosis and have delayed the referral. But the other is that some may not know. So this study showed a lot of gaps, what is happening as far as breast cancer is concerned. So they noticed that there's the women don't know, like literally they don't know about the signs of breast cancer. They don't know how to do the breast examination. They have not been told. And then the attitude about the hospital experience. You and me know that we are overwhelmed as healthcare workers, that people come in huge numbers. And so if someone is coming with a painless breast lump, painless lump, you're likely not to pay much attention, and you're likely to look at someone's wound that is oozing, or the common diseases that we know of. Then some women, it was just fear, just the fear of death. We've had stories that here in my village, stories are that if you're sent to Mulago, then it means it's the last resort. You're likely to die because, again, most of them are presenting late and it is palliative care. So the stories have not been good. And some of them just fear the big hospitals. And then when they hear about a story of mastectomy, it just complicates the case. And so these women end up staying in their homes, and diagnosis is delayed, and then care is delayed, and so the bad news happens. And then just the beliefs about them, our health-seeking habits are really low, that people only go to the hospital when they are in pain. But we know that for breast cancer, by the time it presents with pain, it's already at an advanced stage. And then the other barrier, which was important, is that I don't know how much Dr. Victoria talks since she's within the Cancer Institute, but here in Uganda, we see that all the cases that are diagnosed with cancer, now we have to to refer them to the National Referral Hospital, Mulago. And just the story of going to Mulago, many of these women, you take weeks to convince them, and some of them may not go. And then our healthcare providers, some of them lack training. Most of these women are coming to health center 2s, health center 3s, and who are the people at the health center 2s and health center 3s? Are they trained? Do they know about breast cancer? Even as the doctors, just at the hospitals, how many times are we asking our patients about breast cancer? Are we identifying the risk factors? So some of those things are barriers to the detection of breast cancer at an early stage. And so that complicates even treatment. And the other important thing to note among the barriers is the competing healthcare burdens. We are focusing, and our government and the Ministry of Health is focusing on the common diseases. We are suffering with malaria and so on. So for people to just come up for screening and a checkup, there are few health workers that have the time to do that, because you have a line to clear of only emergencies. And so we are on the line of just putting out fires instead of looking at preventative care. Yeah, if we could go to the next slide. Yes, yeah, so it's those competing healthcare burdens that we have as healthcare providers. But the other important barrier, if you go to the next slide, I will try to rush through since I'm already late in my presentation, is the structural factors. People have been taught that that things are free things, but though our people are poor and they want the free things, some of these services, if you want a free thing, for example, if you need to do histology and the biopsy for it, then you'll have to go to the Uganda Cancer Institute, because now that is where the free service is for histological diagnosis. And so when you meet some of the patients up country, it is just difficult to tell them that you should travel from Kabong to go to the National Referral Hospital for diagnosis, for which I think we could do at the peripheral clinics if one, we are empowered, two, we know what to do, but three, if the pathologists are available in these centers. So as I said, over 80% of our patients present with stage 4 breast cancer. And that is a pain, which is not the case for our friends in the US and other developed countries. So what are the gaps? Studies have been done here in Uganda, even a study done in May 2020. Some gaps have been recognized, and some of them is deficits in recognition of CA breast. Do the people know the science of breast cancer? Do our clinicians ask about breast cancer? Do they inform our patients? Some of these are huge gaps. So part of the recommendations is, first of all, us as clinicians to remember that we need to teach our patients the symptoms of breast cancer. We need to advocate for it. When I listen to radios here in Busoga, they are filled with the people of herbal medicine, and they are telling them information that is wrong. But us who know what it is are not telling them anything. So the people end up going to herbal medicine and forget to come to get worked up, to get screened for breast cancer. So we need to teach the women the signs and symptoms of breast cancer, and to teach them about clinical breast examination, to examine our patients. Let us not only depend on imaging and depend on testing and labs and all that. Let us take full history and let us examine our patients. The other problem, which is a system issue, which we could probably not change, is the centralization of diagnostic testing. Again, radiology, pathology, you have to go to Kampala. I hope the members of MBN are here. I would advise that MBN, goes out to deeper places, to beyond Ginger. I like it that MBN has come at least to Ginger, that we can take our histology and pathology. But how I wish they can extend further, that some of these services are extended. I'm sure some of our patients can afford these services than having to wait for the line at Mulago and the samples. So let us teach our women about the signs of breast cancer, about the breast lumps, about the skin changes and all that kind of stuff. If you could go ahead, is the next slide. I'm trying to rush through. This next slide speaks a lot about breast cancer. As you notice in that picture that is on the screen, we notice, first of all, a pod orange or orange skin appearance of the breast. If a clinician sees that, or if a woman or somebody sees a breast in that kind of manner, I think they should be concerned to at least seek healthcare. But also, in addition to that, is that nipple, the way it's retracted inside. It is a sign that there's something going on in the breast. But some of us as clinicians, we forget to examine our patients. And also, our patients don't know that they have to examine themselves. So it is an appeal to us who are here on this platform today, that we remember that breast cancer is real, breast cancer is around, and that it is killing our friends, it's killing our relatives, it's killing our wives, it's killing, so many people. And so we need to be aggressive about it as clinicians to teach our women the signs of breast cancer and symptoms. The next slide is a slide that I think that such things should be readily available at the health centers, even to health center tools, that you teach women what the signs are, to look out for the skin changes, on their breast, the redness or the rash or the orange skin appearance, the dimpling and the retraction of the nipples. If there's any discharge other than milk, that they should come to the clinic, or they should come to the hospital so that they get examined. If they have lumps in their breasts, let them come so that we can easily examine them. The next slide shows a picture of a lady with another advanced already. It's an advanced disease of the breast cancer. There's already a skin change on that breast, but if you can see that arrow, there's already dimpling. That means that tumor is already fixed on the chest wall. And so many of our women, and I'm sure Dr. Victoria can attest with me, that most of the women that are coming to Marago are in such state. And so we have a role to play. As doctors, we have a role to play as advocates to tell the women about breast cancer and to highly look at screening, because screening has shown that with just education and early diagnosis, early screening, it is likely to reduce at least 30% of the breast diseases if we handle it as fast as possible. Let's rush through the slides, please, for matters of time. I needed to give this basic information for us to rush through, to get at least the basic information that we should deliver to our patients, but also to our colleagues. You can go through that. That's about just breast self-examination, teaching the women how to do a breast examination, a self-breast examination. As those studies showed, most women don't know how to do it. They don't know how to look for lumps in their breasts. But if we can make it a routine thing, then we can save lives. Please, to the next slide. Next slide, please. All these, I just brought them up for matters of, is this difficult for us to put up as signposts, as posters at our clinics, at our hospitals, in the places, and the public places for people to know? Because the more we raise awareness, the more we shall fight this so-called monster of breast cancer, because it literally, it affects lives, and it's killing many of our women, and we need to think about ways of how we can increase awareness. Kindly go to next slides. Those slides are just showing of what is possible for us to put up for our patients. Next slide, please. I'll skip all that, and I'll please go ahead. I'll skip all that, and I quickly run to. Please go ahead. Please go ahead, Prof. Thank you. Just I will run to this slide. It is a huge recommendation that we train professionals to educate the patients. We may not see every patient, but if we can train even VHTs at the low level centers, even VHTs and our midwives, if we can educate them the signs and symptoms of breast cancer, then it is going to help us at least to reduce the risk of getting, at least it's going to help us to reduce this risk by 30% of the death. Because in Uganda, our biggest problem now is that our patients are presenting late. I have a story of a young lady that we operated on just last year. She's 25 now, and she had been to the clinic, she had been to the hospital several times with a breast lump, and one of the, the healthcare providers excised again the breast mass without, proper guidelines. They didn't do a biopsy, they just excised it out. And so this wound, was non-healing, and the lady had issues. So finally she gets to us at the hospital. And so we start working her up, where we did a core biopsy, which came out to be a cancer of the breast. And so we worked her up and finally had to do a mastectomy. And as I speak of today, she has completed her cancer treatment and she's cancer-free. And there are so many of those positive stories that it is possible to cure, to get healed of the breast cancer if you follow the right guidelines. I just wonder if the worst had happened, that this girl did not have a mastectomy, or this girl ended up going to the herbal medicine people, it's likely that possibly she could be dead by today. So here are the few key points that I need to express before we go to the treatment recommendations. In the next slide, that breast cancer is common. But though it is common, not all breast cancer is treated the same, because there's a misconception that whoever has breast cancer must have a mastectomy. Or there's a misconception that whoever has breast cancer must go through chemotherapy. So the treatment plan for breast cancer is personalized, and there are a few things that we base on in the treatment of breast cancer. These are the biology of the breast cancer. Which type of cancer is it? So we do the immunohistochemistry to find out, is this estrogen receptor positive? Is it a HER2 positive, or is it a triple negative? These three will determine on which treatment to start. Also, it depends on the stage of the cancer, and there are so many other factors that we depend on. The fitness of the patient. Can they undergo surgery? Is the disease advanced or not? So treatment of breast cancer is multidisciplinary, and we have to recognize that and to know that if there is a breast cancer, we must work as a team. And so this might need a surgeon. If it is in the US, specifically a breast surgeon with an oncology fellowship. So a surgeon who is also with oncology training. Then we need a medical oncologist, and imaging, we need like a radio-oncologist, and then the pathologists that are vital. All these people are vital in, first of all, helping us to diagnose, but also helping us to manage. And we work as a team. So it is not a one-man thing, but it is a team thing. One of the questions that I frequently get in the office and the clinic is, why did I get breast cancer? So there are non-modifiable risk factors. Of course, like we said, that by mere fact that you're a woman, you're at risk of getting breast cancer, because in the US, 1 in 8 women will get breast cancer in their lifetime. Then age, them over 50, the age of 50, any women over the age of 50, post-menopausal women are likely to get breast cancer in their lifetime. Then family history, if your first degree relative had breast cancer, then you're at a risk. And then the reproductive history, and menstrual history, early menarche and late menopause, and then the genetic mutations like BRCA1 and BRCA2. If someone in the family has BRCA1 or BRCA2, the risk of getting breast cancer in the other breast is increased by at least 5 to 10%. Then people who have had radiation exposure are likely also to have a higher risk of getting the disease. But in the next slide, there are modifiable risk factors that we can look at and possibly reduce the risk of cancer, like the obesity. Can we cut on our weight? And then our parity, the people without children, the women without children are likely at risk of getting breast cancer in their lifetime than those that have children. And then those that breastfeed longer, it is a protective factor than those that do not breastfeed, while alcohol is a risk factor, and hormonal replacement therapies are risk factors plus use of contraceptives, but lack of exercise also puts you to risk of getting breast cancer. Now, the American Cancer Society has recommended that women of the age of 40 to 44 years should have their choice to start annual screening mammograms. Now, that is in centers like the US and, maybe in Kampala, where mammograms are readily available. But what about in our setting here in Uganda? How many towns have mammograms? They are very few. So it is a challenge. But in the US, that is the recommendation. And for the women between 45 and 54 years to have annual mammograms, and for those older than 50 years to switch to mammograms every 2 years. And the College of Obstetricians and Gynecologists, American, they recommend a clinic exam for women in their reproductive years, at least 1 to 3 years, to go for a checkup, which is not the case for our Uganda. So treatment, again, we look at staging of the cancer, and I want to go into those details of the staging of the cancer and the biology of the cancer. What is the tumor grade? What are the tumor markers? And then it is from those that we will, if you could go to the next slides, I'm looking at my time and it's almost done. So if this is the treatment approach. Okay, the diagnostic approach is first of all the clinical examination. If you see a lump, then it is the ultrasound scan. Could you go to the next slide? Then ultrasound scan. From the ultrasound scan, we'll be able to see, is this hard nodule, soft tissue, which kind of mass is this? And then that is on the Ugandan setting. But in the US setting, it will be a mammogram next. However, in our Ugandan setting, in our low resource limited settings, it's advisable that after the clinical examination, and if there is a suspicious mass or you've palpated a mass, it's advisable that you send them for an ultrasound scan. And it is then from that ultrasound scan that you can think of a core needle biopsy, and because that is confirmatory. And then if it comes out to be positive, then you need to stage this cancer. In the US, usually they do the MRI, but here in Uganda, the CT scan staging is good for you to, for us to know, is it advanced to other places or not? Please go ahead. I'm trying to run ahead of my time. So, so we've diagnosed the cancer. We've staged it. Second, the third is to know which kind of biomarker is it. Is it estrogen receptor positive? Is it HER2 positive? Or is it triple negative? If it is positive, ER positive, estrogen receptor positive, then that tamoxifen has shown to be receptive, like it can respond to that. But if it is HER2 positive, then Herceptin is recommended, sometimes combined with chemotherapy. But then if it is a triple negative, chemotherapy is recommended. So we grade them, we grade these into local regional treatment. You go to the next slide, and systemic treatment. What comes first and why? So go to the next slide. So the local regional treatment is where now surgery comes in, either to do, so there are two schools of thought, but let me first of all speak in the Ugandan setting, and then speak of what is standard. The next slide, please. So in the Ugandan setting, for our women, if you are diagnosed with breast cancer and we've staged it according to the stage of the breast cancer and according to the biomarkers, is it estrogen receptor positive, HER2 positive, or triple negative, then we'll consider surgery. Surgery, in Uganda, it is advisable that depending on the stage again, some are inoperable if it is stage 4, some of them are inoperable. You want to first of all give neoadjuvant chemotherapy to reduce the tumor, and then you remove it. But the standard is, if it is operable, surgery first, which is a mastectomy, and then of which after the mastectomy you take still the tumor for the tumor margins to see if all of it is taken. And if it is, so after the surgery, you want, if it is ER positive, then the women are put on tamoxifen, which runs 5 to 10 years. But if it is HER2, then they are put on Herceptin. And if it is a triple negative, then chemotherapy is recommended. And sometimes, depending on the medical oncologist, they might need to have a radiation in addition to the chemotherapy. So, so that treatment is personalized. It's according to your stage of cancer. It's according to which kind of tumor marker that is concerned you have, and then it's a discussion as a team. Now, mastectomy, not every patient must have mastectomy. Some of them are inoperable and it is extended. And so some women may have to go direct to chemoradiation and then later on might consider that. In the US, and well, here, one of the biggest questions I've had from the women diagnosed with breast cancer is, are you removing my breast? And so it is a big challenge. In the US, we can consider a lumpectomy, where you just remove the part of where the tumor is with the tumor margins, and then you do reconstructive surgery and you reserve the nipple. But after the lumpectomy, a patient must go through radiation to avoid the recurrence. That is the US side. Now, here in Uganda, those discussions are there. And some women have said, man, don't dare remove my breast. That depends on the size of the breast and the size of the tumor. But if it's a small tumor and it has good breast size, that is a consideration. However, it is a must that if that line is taken, the patient must have radiation after that to avoid recurrence. And you all know the challenges of our radiation here and the patient number. So such patients that would love to go that line, you possibly would love to be able to arrange the radiation, possibly out of the country, or if it is within the country, to book ahead of time so that they don't have the recurrence. With that, allow me conclude with just a few remarks. Breast awareness and breast self-examination is vital in reducing the death rate of breast cancer, because the earlier the diagnosis, the earlier the referral, or the earlier the treatment, and the better the outcome, the better the prognosis. So in in Uganda and here, I would highly recommend that as clinicians, we take good clinical history and clinical breast examination. And where possible, whenever possible, to always give these women a chance to come back for examination, even when they are not in pain, for us to always take a full clinical history and examine them. Thank you very much.